This conference will now be recorded.
So I've finished with all these competencies, competency 1, 2, 3. Now this is the fifth competency which is mentioned in your curriculum. So this I'll be teaching today, and on the last day I'll be teaching the fourth competency. Okay, so I think today I've kept similar colors, purple color, the tumor immunity. So following which I'll be just telling about the epidemiology of cancer and how the tumors are graded and staged. So epidemiology of cancer will also be taught to you in community medicine, but you have to just know the idea, the outline of these two subtopics. But tumor immunity is an important, it's a core competency which you have to know. So we'll start with the person, the very first person who researched on tumor immunity, Paul Ehrlich. So he was an immunologist, hematologist, and also has done research on antimicrobial chemotherapy. He has won Nobel Prize award in physiology and medicine or medicine. Now he was the first person to get the concept that tumor cells can be recognized as foreign in the body, and anything which is foreign in the body is eliminated by the immune system. So that idea, that concept, he was the first one to conceive. Can you tell he's famous for what else, what other contribution which he made towards medical field? Any other important contribution which he made towards medicine? Is famous for what else? Do you have an idea? He was a person now to found out the cure for syphilis. He was the person. Okay, so we'll go with tumor immunology. Now, this is the normal cell. So normal cell, they express normal antigens on its surface. Now, when this normal cell is transformed into a neoplastic cell or a malignant cell, what happens is that this malignant cell expresses new abnormal antigens on the cell surface. New antigens which are abnormal antigens or the proteins on the cell surface, and it loses some of the normal antigens. Because the normal, in the place of the normal antigen, the abnormal antigen will be expressed. Okay, so this malignant cell becomes antigenetically different from the normal cell of the host, and anything which is foreign is recognized by the immune system. So these abnormal new antigens which are expressed on the tumor cell or the malignant cell, it triggers an immune response. So you all know about immune, about the immunity in our body. You have the innate immunity and you have the adaptive immunity. So it is the adaptive immunity which is triggered in the body following any formation or entry of any foreign antigen in the body, or formation of any foreign antigen in the body. And in the adaptive immunity, we have humoral immunity and cell-mediated immunity. In case of tumor immunity, it is the cell-mediated immunity which plays an important role in recognizing the foreign antigen and eliminating it from the body. So that is called as immune surveillance. That means to say the immune system, it surveys the whole body, it recognizes the malignant cells and it tries to destroy the malignant cells. Now, what are those immune cells which does this function? So we have the cytotoxic CD8 T lymphocytes, and we have the natural killer cells, then there is macrophages and dendritic cells. And there is one protein now called as major histocompatibility complex, MHC class 1 protein, which is a protein receptor which is expressed on all the nucleated cells of the body. So all these cells as well as this receptor protein play an important role in immune surveillance. So I think about inflammatory reaction, the stromal reaction I've explained, I think in the very first class. So we have a desmoplastic stromal reaction and an inflammatory reaction of the stroma in response to the islands of the tumor cells present in the extracellular matrix or in the connective tissue. So how the stroma responses reacts to this tumor islands, there will be in formation of a lot of lymphoid cells, or these lymphoid cells are recruited from the circulation. So infiltration or formation of lot of lymphoid cells. If you're seeing all these purple dots, all these are the lymphocytes. They are cytotoxic CD8 T lymphocytes surrounding all these tumor islands. So these purple dots, they are the nucleus of that lymphocyte. So you all know the lymphocyte will have a very scant cytoplasm and the whole of the cell is occupied by the nucleus. So it is the nucleus which will be seen under the microscope. So that will be the most prominent feature. So all these lymphocytes are recruited from the circulation and they multiply within the stroma in response to all these tumor islands if the person immune system is good, and they try to destroy the tumor cells. So this is a cell mediated immunological response by the host to destroy the tumor cells, which I have explained in the first class. Now, initially, how these tumor antigens were classified when I was an MBBS student. So it's classified, they were classified into only two categories, that is tumor specific antigens. So since as mentioned, specific, they are present only on the tumor cells, they are not present on the normal cells. Next, you have the tumor associated antigens, which are present on the tumor cells as well as on the normal cells from where the tumor cells have been originated. So those are tumor associated antigens. So this was a classification which was followed before, but now the latest classification is based on the molecular structure and the source of the antigen. So this was the field which has been researched by immunologists. So that's a branch which is coming up nowadays along with genetics. So they are classified under 7 categories. The first one is the products of the mutant antigens. So the mutant antigens, they release some abnormal proteins or lead to the production of abnormal proteins in the tumor cells. Next are the oncoproteins from the mutant oncogene, that is the product of the mutant RAS or the products of cyclin dependent kinase 4, that is the cell cycle protein, that abnormal or the mutant CDK protein or the product of it. Next, protein products of the tumor suppressor gene, that is mutated P53, mutated beta catenin. So all these are considered as foreign. Now, in melanocyte, in a normal melanocyte, there's a protein called as melanocyte specific protein. So which is expressed in normal amounts in the normal melanocyte. Now, if that melanocyte undergoes a malignant transformation, so it is the tumor is said to called as melanoma. In that malignant melanocyte, the whatever protein which was expressed in normal amount, now the same protein is overexpressed in that tumor cells, or it is the quantity of that protein is more than the normal. Okay, so that is also considered as a foreign. So overexpressed cellular protein, example they have given in your textbooks as melanocyte specific protein in melanoma. Okay, so usually this protein is present in very minimal amounts in the normal melanocyte. But if that melanocyte undergoes a malignant transformation, in that malignant cell, it is expressed in more amounts. So that is abnormal. Okay. Now, there is one more protein which is encoded by the gene, that is melanocyte antigen gene. M stands for melanocyte, A is antigen, G is the gene. Now, this gene is not expressed in the melanocyte. So, you know, melanocyte, it also has a nucleus. The nucleus will have the chromosome. So, genes are present on the chromosome. So there in those genes, there's one gene called as MAGE gene, which is not expressed in normal melanocyte. Now, if that normal melanocyte undergoes a malignant cell, gets transformed into a malignant cell. Now, in that malignant cell, there will be abnormal expression of that gene, leading to formation of abnormal proteins in the cytoplasm of that malignant melanocyte. Okay, so abnormal expression of the cellular protein, which is normally is silent. The gene is silent in the normal cell. It gets expressed when that cell undergoes malignant transformation. Next, the fifth category is which I've already mentioned in the previous class, the tumor antigens from the viral oncoproteins. So E6 and E7, that human papilloma virus, in case of cervical cancer, so this is considered as a foreign antigen. And Epstein-Barr virus, EBNA protein in case of Burkitt's lymphoma. So this protein is also considered as foreign. Next, CEA, they are the, and AFP, they are the oncofetal proteins. So this carcinoembryonic antigen and alpha fetoprotein, I think you already know about this in your biochemistry. So these are expressed in very high levels in the fetal tissue and in the cancer cells, but not in the adult tissue. So the levels of alpha fetoprotein in the blood is increased in case of hepatocellular cancer, and carcinoembryonic antigen is increased in case of colon cancer. So they are tumor markers. I think you already have the short note in your final exam about tumor markers. Next, the tumor cells, they express abnormal molecules on its surface. Some of the tumor cells, they express. So what molecules they are? Some abnormal glycolipids, glycoproteins, and mucin. So these molecules can be released into the circulation. For example, cancer antigen 125 in case of ovarian cancer, and musicarmin 1 in case of breast cancer. So full forms, if you can remember, you remember. Otherwise, abbreviated forms are enough. MUC1 and CA125. So these are all our tumor antigens which have come now. So when I was studying MBBS, they were not there, but now it's there. So always we have to update our knowledge with all the recent additions. Next, how these tumor antigens are recognized by the immune cells, and how the immune cells destroy this tumor antigens. So that is the next part of our discussion. So normally, if you take this is a normal cell, and it is leading to the production of the proteins. So all these proteins are considered as self proteins. Okay, so all the proteins of the cell, they are usually presented by major histocompatibility class 1 receptors. They usually present the proteins to the immune cells. Now, since these proteins are considered as self proteins, not foreign proteins, they are not recognized by cytotoxic T lymphocyte as a foreign antigen. Okay, and there is no immune response. So when does it occur? So since I already stated before, when the self protein becomes abnormal. So when can it become abnormal? When the gene which encodes that protein is mutated, leading to the formation of mutated protein. So that mutated protein is considered as a foreign antigen, and it can be, and the MHC class 1 molecule, it's the receptor protein which presents that foreign antigen or the tumor antigen to cytotoxic T lymphocyte, so that the T lymphocyte can destroy that cell as well as that protein. Now, what are the other reasons where the abnormal protein can be presented? It is that, so when the proteins are overexpressed in the tumor cells, for example, I've given you melanocyte specific protein in case of melanoma, or the MAG protein, so which is usually silent in normal cell and gets expressed in the abnormal tumor cells. So in such cases, the protein is recognized by cytotoxic T lymphocyte, as well as it also recognizes the oncogenic viral proteins. Okay, so in all these cases, the immune cell of the body recognizes the tumor cells and destroys it. Now, how does it destroy? So here you have the cancer cell, yes, and here is the cytotoxic T lymphocyte. So here you can see this is the MHC class 1 molecule, and this is the tumor peptide or the tumor protein. So it presents this tumor peptide to the cytotoxic T lymphocyte. Now this T lymphocyte, it also has one receptor on the cell surface, that is TCR receptor. Very simple, T cell receptor it is. Okay, TCR is, T stands for T lymphocyte, C is cell, and R is the receptor. So this receptor binds to this abnormal mutant protein and MHC class 1 complex. Now following the binding, what happens? This receptor gets activated, which in turn activates signal transducing protein within the cytoplasm. So that pathway is P1-3K pathway. So that pathway gets activated. It's a signal transducing pathway. Okay. So this pathway in turn activates the cytotoxic granules within the lymphocyte. So that cytotoxic granules, it contains two cytotoxic substance, which is the porphyrin and granzyme B. Okay, so these cytotoxic granules, they come onto the surface of the lymphocyte and they release this toxic granules. So what does this toxic granules do? You have this porphyrin. So porphyrin, what does it do? It drills hole in the cell membrane of the neoplastic cell. Okay, or it perforates the cell membrane of the neoplastic cell. Now through that drilled hole, the granzyme B enters into the neoplastic cell, and this granzyme B activates the caspases enzyme within the neoplastic cell. So what is this caspases enzyme? Yes, it's an apoptotic enzyme which causes apoptosis of the transformed cell. So that is the mechanism involved in killing of a malignant cell by cytotoxic T lymphocyte. Okay, so have you understood this picture? We'll go to the next. Now, so this is the tumor cells. So I've mentioned about other cells like dendritic cells and macrophages. They are the antigen presenting cells. So what do you mean by this? So I told you that MHC class 1 molecule, it is expressed on the surface of all the nucleated cells in the body. So this MHC class 1 molecule, it recognizes the tumor antigens which are released by the tumor cells, and it attaches to the new tumor antigen and phagocytizes the tumor antigen, and then it travels to the nearest draining lymph node through the afferent lymphatic vessels, and it presents the tumor antigen to cytotoxic T lymphocyte, which then destroys the tumor antigen. So the same is the function of the macrophage. So both have the same function. They are called as antigen presenting cells because they present the tumor antigen to the cytotoxic T lymphocytes. Now what happens as the tumor increases in size? It outgrows its blood supply. When it's not receiving sufficient blood supply, some of the tumor cells they undergo necrosis. So from those necrotic cells, so certain signals are released which are called as danger signals or damp signals, it's called as. So these signals, they interact with the dendritic cells and the macrophages. So following the interaction with the dendritic cells in turn sends signals to the nearest draining lymph node, and it stimulates the T lymphocytes such that the T lymphocytes, it migrates towards the tumor tissue, and it leads to and it causes the damage or destruction of the tumor tissue because it recognizes the antigens which are expressed on the tumor cells as a foreign antigen, and then it goes and attaches to the foreign antigen with the help of the TCR receptor. Okay, so that is the anti-tumor mechanism which is involved. So the same is the function of natural killer cells also. It has the same function as that of the cytotoxic T lymphocyte. So next, so till now I have spoken about how the immune system can damage the cancer cells. Now, can the cancer cell escape from the immune system? Yes, it can be other way around, because if you see the judicial system, we catch the criminals, but all criminals are not there in the prison. Yes or no? Some of them, they escape. Like that, if you consider criminals as tumor cells, so some of the tumor cells can also escape. So what are the mechanisms in which the tumor cell can escape or it can evade the immune system, such that the immune system can't recognize those cancer cells, or those cancer cells are resistant to the immune system? So what can be those causes? So the causes are when the tumor cells, they don't express any antigens on the cell surface. That can be the cause. Failure to produce tumor antigens. So some of the tumor cells are like that. And when the MHC gene is mutated, so there is no MHC class 1 receptor on the cell surface of the tumor cell. So nothing is there to present that abnormal protein to the T cells. So no immune response. Next, when the tumor cells secretes certain cytokines which can cause suppression of the immune system. So they're called as immunosuppressive cytokines. So what these cytokines do, they prevent the activation of TCR, that is T cell receptors. So if TCR is not activated, the signal transducing protein does not get activated, and cytotoxic granules are not released, and tumor death cannot occur. Okay, so these are the reasons when the tumor cells escape death from the immune system. Now recently immunologists have also found out that not only the activation of T cell TCR receptor is needed, but there has to be activation of one more receptor expressed on the cytotoxic CD8, which is called as CD28 receptors. So activation of both the receptors are required for the activation of signal transducing pathway, that is the P13K pathway. Now, what happens is that some of the tumor cells they leads to activation or expression of one more receptor on the surface of T cell, which is called as cytotoxic T lymphocyte A4. So this receptor is usually hidden within the membrane of the receptor. So tumors have found out the way of expressing this receptor on the surface of the T lymphocyte. So what does this receptor do following signals from the tumor cells? So this receptor, it attaches to the ligand, which is also a receptor, that is B7 ligand, either on the tumor cell or on the dendritic cell. So this B7 ligand is also expressed in all the nucleated cells. So this B7 ligand has, instead of getting attached to CD28 receptor for activation of signal transducing pathway, it binds to one more receptor called as cytotoxic T lymphocyte antigen A4 receptor on the which is normally is hidden within the membrane, but the tumor cells, they send signals such that this receptor gets expressed. So this CD28 does not get bound to this B7. So only if it gets bound to the B7, the activation of CD28 along with the activation of TCR is needed for the P13K pathway to get activated. Okay, so they have designed certain immunotherapy drugs which have anti CTLA4 activity. So these are the drugs which bind to this anti-CTLA4 drug. It binds to that inhibitory receptor, which prevents the activation of P13K signal transducing pathway. So by binding to this receptor, now CD28 receptor does not face any competition from this inhibitory receptor. So it binds to this B7 ligand, which is present on the dendritic cell as well as the tumor cell. So following the activation of this receptor along with the activation of TCR receptor, P13K1 pathway gets activated and the cytotoxic granules are released, killing the tumor protein as well as the tumor cell proper. Okay, so this is the recent thing which is there in your recent edition. It's not there in the previous editions. So that's how the drug can kill the cytotoxic T lymphocyte. So if it is not possible endogenously, so the we have created an exogenous source, exogenous weapon to destroy the tumor cells. Now, similarly, like this only, the tumor cells, they not only expresses that hidden receptor, that cytotoxic T cell 4A receptor, but also it causes increased expression of one more receptor on the T cell, which is PD1 and 2 receptor. PD is programmed that 1 and 2 receptors on the T cell. So these are also inhibitory receptors which prevents the activation of signal transducing pathways. So the T cell does not get activated at all. So the receptor is present on the T cell, and its ligand is present or will be present on the tumor cell. Okay, so following attachment to this ligand, so there is no activation of TCR. Okay, that is T cell receptor. So signal transducing pathway does not get activated. Now there are certain drugs. That is, they have designed certain drugs which are which have the property of anti-PD-1 and anti-PD-1 and 2 ligand. So these drugs, they attach to the PD-1 receptor on the T lymphocyte, as well as to the PD-1 ligand on the tumor cells. So this by doing so, the TCR receptor along with CD28 receptor gets activated, and so that it can send signals to the cytoplasm for the release of cytotoxic granules which can kill the tumor cell. So this is the recent one, which are included in the recent edition. Now, in addition to this, in the previous class, I have mentioned two other things where the drugs have they have designed certain drugs to prevent the action of certain substances in the body. Can you remember? Maybe in the first class or maybe in the second class, something else I have mentioned to prevent the action of that. So what are present at the ends of the chromosome? Now you can remember. Clue, I've given you a clue. What is present at the ends of the chromosome?
Telomeres.
Yes.
Telomeres.
Yes, so something I mentioned in the previous class, certain drugs also they have designed which prevent the reactivation of telomerase enzyme, so that the telomeres does not get reduplicated and the cell can exit from the cell cycle. So all these, so in the beginning, which I've told you about immunotherapy, they kill the tumor cells. So the telomerase enzyme, the drugs, they don't kill the tumor cell, they prevent the further growth of the tumor. So similarly, I mentioned about matrix metalloprotease. So what's the function of this matrix metalloprotease?
The degradation of extracellular matrix.
Yes, degradation, so that a space is created in the connective tissue for the tumor cells to grow. So they have designed certain drugs which prevents the action of matrix metalloprotease. Like that, there are other targeted therapies which prevents the activation of the mutated receptors, growth receptors, such as mutated KIT, mutated HER2 in case of breast, mutated EGFR in case of prostate, mutated BRAF in case of colon, and not only the receptors, even they prevent the activation of mutated signal transducing pathway, that is P13K in case of brain. So these therapies, they don't target the genes, they target the abnormal proteins which are synthesized by the mutated gene. So by targeting the abnormal protein, you can prevent the further progression of the tumor. So that's why all it's coming to the molecular level. The diagnosis is coming to the molecular level, finding the root cause, and the designing of the drugs, formulating the drugs also, it's coming to the the root level. Okay, so that's how they design the drugs. So pharmaceutical industry is also uh, very coming up field it is. So after doing MD pharmacology, so one either can teach pharmacology, or you can, if you are very adventurous and all that, you can go to that research field, pharmaceutical companies. So it's very good in foreign countries actually. better than in India. So these are, so that's about tumor immunity. So we have a tumor immunology. It usually comes as a short note for you. So whatever I taught you, that's sufficient. So this is one extra knowledge I'm telling you. So a little bit about grading and staging and epidemiological factors of the tumor, even though they are not mentioned in your core competency, but you need to know an idea about it. So they are used to predict the tumor behavior and also to guide the therapy after a malignant tumor is detected. It's easy actually. I've already mentioned in the previous class, but not under this heading. So I've told you about the anaplastic cell. So one has a very has no resemblance also to the normal cell, both structurally, morphologically, and functionally. So usually benign tumors have the similar features to the normal cells. Then again I told you in malignant tumor they are differentiated into well, moderately, and poorly. So how they are differentiated into well, moderately, and poorly? Not only the based on the architecture which I have mentioned, but also on the now I'm mentioning also on the number of anaplastic cells in the tumor. So if the percentage of anaplastic cell is less than 25%, then that malignant tumor is said to be well differentiated. If it is between 25 to 75%, it is moderately differentiated. If it is more than 75%, it is poorly differentiated. And if architecture is also completely lost, and total 100% they are anaplastic cells, then such tumors are called as anaplastic tumors. Okay. So this grading, so this we can see only under the microscope, okay, not on the naked eye. So it is done on the pathology. It's done by a pathologist. So on pathology basis only this grading can be done. But staging can be done by a clinician. So it tells the extent of the tumor within the patient. So there is two types of staging, Tnm staging and agency staging. So what is this Tnm staging? T stands for tumor, N is regional lymph node, whatever the lymph nodes are there in that vicinity of the tumor, draining that tumor, and the metastasis. So it was first done by this organization in Geneva. So what is this T? So it is again divided from T0 to T4. T0 is there is no tumor. This is it's in situ. So I have mentioned in the very first chapter carcinoma in situ. When the epithelial cells, malignant epithelial cells, at that stage when they are called as dysplastic cells, when it involves the whole of the epithelium without any invasion into the underlying connective tissue, then it is called as in situ. So when we see that under the microscope, we stage it under TIS. Next, from T1 to T4, it depends upon the size of the tumor. So which is somewhat different for different tumors. For example, T0 is 0 to 1, 2 centimeters, 2 is 2 to 4. 3 is 4 to 6, and more than 6. So it is different for different tumors. So at this stage that is not required. So just you have that idea. So it depends upon the size of the tumor. So in detail you will get only in WHO tumor books. So which is important when you reach your post graduation level or when you do the super specialty courses. So not at this stage. So don't break your head. So but you need to have just one idea. So how the staging is done. Next, you have from N0 to N3. N0 means no lymph node. Then N1, N2, N3 depends upon how many number of lymph nodes are involved, whether there is unilateral involvement or bilateral involvement. Similarly, M0 to M1. M0 no metastasis. M1 there is a distant metastasis. So that's how staging is done. Now, after staging, So there's one more staging with which the clinicians do, so which is important for the prognosis as well as how they are going to treat the cancer patient. So if the stage is very high, so they have to give more rigorous treatment to the patient, and the prognosis will also be poor. So it's a combination of the T and M. Okay, that's how the staging is done. So this is not required, it's only for your information's sake I'm giving you. Now the epidemiological factors of the cancer, I think you will have in your community medicine chapter also. So it's not so important, it's not a core competency, but just for the completion's sake I'm giving you an idea what it is. So it is categorized into three categories. So predisposing factor, pre-malignant condition, and hormones. So coming to familial and genetic factor. So this table I have already mentioned in the previous classes. So if any patient come with the, for example, history of breast cancer, if a woman is coming with the history of breast cancer, so you have to definitely ask the family history, whether mother has the similar problem, her sister has, or cousins has, grandmother has. Now, in case if she tells yes they have, then you have to send for genetic analysis. So breast cancer 1 and breast cancer 2 gene. So these are some of the predisposing factors in familial genetic factors. Now racial and geographical factors. So in white Europeans and Americans, this is all the survey they usually do. The cancer survey is usually done wildward, and they just found out which cancer is more in which racial and geographical area. So all these cancers are common in white Europeans and Americans, liver and cervical cancer in Africans, in stomach cancer in Japan, nasopharyngeal cancer in China. In India, both the sexes, there is risk of cancer to the oral cavity as well as upper aero digestive tract, that is the nasopharynx, larynx. And in females, cervical and breast cancer. Now, in case of hepatocellular cancer, the main etiological factor in India is hepatitis B virus and hepatitis C virus, whereas in Western countries it is alcoholic cirrhosis. So you just need to know, have an idea of this. Okay. Next, environmental. Now here, in this section, one cancer I haven't mentioned, which I mentioned in the previous class, which cancer is common in white population than in black population. Just one common sense. What is lacking in white skin people?
Melanin.
Yeah.
Melanin.
So melanoma is more common in white skin people than in black skin population. Okay. Now environmental and cultural factors. So cigarette smoking, oral cavities. So some of the villages, they have that reverse smoking. Okay, that smoke and they keep inside. More prone for cancers of the buccal mucosa. So they damage all the cells, and they can damage even the DNA of the cells also. Who knows why they do. Next, pharynx, larynx, lungs, esophagus. Okay, like alcohol, oropharynx, larynx, and liver, and multiple sexual partners. So cervical cancer or pineal cancers, and betel nut chewing. So I mentioned also in yesterday. So it's a carcinogen. So cancer of the buccal mucosa and tongue. Now, industrial substance like asbestos, lung cancers, and mesothelioma. It's a malignant tumor arising from the mesothelial cells of the pleura. That's just a general information for you. Next, incidence of cancer. Which cancer is more in which age group and gender? So in men, adult men, so all these cancers in the kept from most common to the less common. Okay. In women, breast cancer, cervix, ovary, endometrium, and in children, so these cancers are very common. Can you tell which Indian cricketer has cancer of testis? Now it's not playing now. Do you know? The Indian cricketer. I forgot his Yuvraj Singh. So Yuvraj Singh had seminoma testis. Okay. Now it's not playing nowadays. Undergone chemotherapy. And can you know which female actress had ovarian cancer? Female heroine. So, do you know Mani? Yeah. What one? Yes, ma. In Manisha Koryala, I think Manisha Koryala. Do you know her? She's a heroine of 90s. Bombay, it came, no? The film called Bombay. You know? Shah Rukh Khan, Manisha Koryala, and Preeti Zinta. So she had ovarian cancer and undergone chemotherapy also. Children, I don't know anything about celebrity children. So these are the tumors which are common in children. So pre-malignant conditions which have to be treated at that stage. If not, they will progress to cancer. So cervical intraepithelial neoplasia in case of cervical cancer, endometrial hyperplasia, endometrial cancer, Bowen's disease, actinokeratosis of the skin. So they are pre-malignant condition. Oroleucoplakia in case of cancer of buccal mucosa and tongues. All these are the pre-malignant conditions. So one condition I didn't mention here. Pre-malignant condition of the skin where the DNA repair gene is defective. What is that condition? Nucleotide excision repair gene is defective in the pre-malignant condition. You remember? Xeroderma pigmentosa. Okay. And some benign and non-neoplastic tumors like adenomas of the intestine. So it has to be diagnosed, otherwise it can progress to carcinoma of the intestine. Similarly, neurofibroma, so benign tumor of the peripheral nerves. If we diagnose, it has to be excised immediately, otherwise it will progress to neurogenic sarcoma. Similarly, some inflammatory conditions, so liver cirrhosis, you all know, so it can progress to hepatocellular carcinoma. Similarly, ulcerative colitis, it's an inflammatory bowel disease. In detail, you will come to know in the intestine chapter. It can progress to colorectal carcinomas, chronic bronchitis to bronchial cancers. So infection. So I already explained about human papillomavirus, oncogenic virus. So etiological factor in cervical cancer and hepatitis B and C virus in liver cancer. And there's one more bacteria. And this is a bacteria, it's not a virus. Helicobacter pylori. So it's implicated in the pathogenesis of gastric cancer. Now these are the hormones. So exogenous estrogen, if it is given, it can predispose to endometrial carcinomas in older age group, oral contraceptive pills for breast cancers, anabolic steroids for liver tumors. So this is just about information, extra information I'm giving you. So that's about tumor immunity along with a little bit of epidemiology of cancer and an idea about how the cancer is graded and staged. So the next last class you will be having on Tuesday about the last, the fourth competency. So this was the fifth one. So this is the fourth competency which is mentioned in your curriculum. So host effects and paraneoplastic syndrome and a little bit about how the tumor is diagnosed. Okay. Okay then.